Good morning, everyone. My name is Jason Samarasena. I'm an interventional gastroenterologist at the Digestive Health Institute at UC Irvine. And it's my pleasure to kick us off here by giving a lecture on improving mucosal imaging in Barrett's esophagus. It's time to up our game. These are my financial disclosures. My personal disclosure is I love endoscopic imaging, and I'm hoping over the next 20 minutes to share some good information about how we can improve our examinations of patients with Barrett's esophagus. And why is that important? Well, one of the reasons is esophageal adenocarcinoma is rising in this country, and the 5-year survival of this cancer still is really dismal, about 18%. So how do we change this trend? Well, one idea is to look at the pre-cancer to esophageal adenocarcinoma, which is Barrett's esophagus. So fortunately, there's a fairly stepwise evolution of Barrett's to esophageal adenocarcinoma. And well, we start off with our stratified squamous epithelium, and due to injury from acid and likely bile, it leads to chronic inflammation. And then a certain group of the population has the genetic predisposition for this inflammation to lead to Barrett's metaplasia. Then there's a fairly stepwise progression from Barrett's to low-grade dysplasia, high-grade dysplasia, and then adenocarcinoma. The question is, can we see dysplasia endoscopically? And if you look at our surveillance guidelines, they would argue that you really can't see dysplasia endoscopically, and as a result, it tells us to do the Seattle protocol biopsy, which is 4-quadrant biopsies every 1 to 2 centimeters. If all those biopsies come back without dysplasia, then you bring patients back based on these intervals. The problem with this is surveillance has not shown to really work to prevent cancer. And there's many studies like this one that have shown that multiple people in surveillance protocols have gone on to develop high-grade dysplasia and cancer. So why are we not picking up early cancer and dysplasia in these surveillance programs? Well, one reason might be we're just not taking enough time to inspect the mucosa, and there's data to support that. Another reason might be we don't know exactly what we're looking for. And part of that may be there's really limited training in Barrett's imaging in a typical 3-year gastroenterology fellowship in the US. But I would attest that we actually have very good tools to do high-level Barrett's imaging in 2021. We have high-definition endoscopy. I'm going to talk about distal attachment caps, virtual chromoendoscopy, taking your time and freezing, endomicroscopy, and above all else, image interpretation skills. So let's talk about the scope. Well, we've seen a dramatic evolution in the endoscope, starting with the gastrocamera in the 1960s. That's kind of what that looked like. The fibroscope. Then we got to video scopes, and we were able to kind of see images like this. This is a low definition image of somebody's esophagus with Barrett's. But then things got really sophisticated with high fidelity series scopes and processors. Now we really got amazing endoscopic capabilities. So, and the level of detail here is just fantastic. And I really believe endoscopy has really reached the limits of human visual capacity, meaning that this is essentially a 2K resolution image. If we move to 4K, 8K, 16K, adding more pixels and resolution won't really further the clinical value of that imaging. I believe we've already reached that point. So with that said, we've already got great endoscopy equipment. Now, how can we use it effectively? So one of the tricks is using a distal attachment cap. And anybody that does endoscopy with me knows that this is literally my best friend. It's a very simple device. Traditionally, these were used for endoscopic submucosal dissection procedures to assist with something called traction. But now, actually, it's being used more in kind of routine endoscopic procedures, including colonoscopy, to improve polyp detection. It fits right on the top of the scope. This little side hole, the orientation of side hole doesn't really matter. There's certain sizes that fit different scopes. This is the position of the cap for an ESD procedure. And one of the things you might say is, well, this is really kind of obscuring a lot of the visual field here. And I would agree. And so for just sort of an upper endoscopy for high quality imaging, this is usually the position that we put the cap. So further back, you don't see as much of the cap out. There's almost like a plastic meniscus here that you're seeing. And this is sort of like an ideal position. And you're not really losing a lot of the visual field by the cap being on the scope. With the cap on, there's really never a readout. You're maintaining a set distance away from the tissue, and that can be really, really helpful for imaging. Also, the cap edge actually stabilizes the tissue. But now with the cap on, the mucosa is almost sort of pinned, and sometimes you can pin it with sort of one edge, sometimes you pin it with more of the rim of the cap, but it really works extremely well. And so let's just take a quick look at this video. And here you can see I'm getting really, really close to the tissue, ever getting a readout, because the cap is sort of kind of restraining the tissue from coming too close to the camera. And because of that, and I'm moving a little bit quickly here just for the purpose of this video, I'm able to kind of look carefully at multiple areas of this patient's Barrett's esophagus and get sort of this nice clean look of the tissue. So moving on to virtual chromoendoscopy, and narrowband imaging uses 3 discrete bands of light. When combined, it offers extremely high contrast image of the tissue surface. So capillaries on the surface are displayed as sort of this brownish color, and veins in the subsurface are sort of displayed in this sort of cyan type color. Virtual chromoendoscopy can be important for just detecting Barrett's because it produces sort of this nice high contrast between the stratified squamous and the columnar epithelium. But more importantly, it can be very useful for detecting dysplasia within Barrett's. So the Barrett's International NBI group, or the Bing group, came up with this criteria. Without getting into too much detail about the criteria, they're sort of looking at mucosal pattern and vascular pattern. And if you have an irregular mucosal pattern or an irregular vascular pattern, then this is more likely to be consistent with dysplasia. So here you've got this kind of regular pattern, mucosal and vascular pattern. And here you've got more of an irregular pattern, and this may be more consistent with dysplasia. These are non-dysplastic patterns that we commonly see. And when you see something like that, these are abnormal mucosal patterns and vascular patterns that are more consistent with dysplasia. And again, with the high quality endoscopes that we have now, we can actually differentiate this very, very easily. The next thing to keep in mind is freeze the image. And it's not just freezing the image. It's really more of a message to sort of take our time. So this has been shown in studies where the longer the time you spend inspecting the mucosa, the higher the likelihood you're going to find an endoscopically suspicious lesion and a higher chance of detecting high-grade or early cancer. And that sort of makes sense. But in this study, a Barrett's inspection time of longer than 1 minute per centimeter was associated with finding more endoscopically suspicious lesions. So I think that 1 minute rule, I think it's a good one. If you're looking at somebody with a 3-4 centimeter segment, spend about 3 or 4 minutes looking. That's a good rule of thumb. The other thing I'm going to talk a little bit about is endomicroscopy, and there's probe-based confocal laser-induced endomicroscopy, and hopefully I'll be able to show you a demonstration of that in the live case. But essentially, this is a confocal laser endomicroscope that's been miniaturized for endoscopy, and essentially this is a blue light laser, and after giving some IV fluorescein, We're able to touch the probe to the tissue really anywhere in the GI tract. And we're able to get about a 1,000 times magnification microendoscopic image like we're seeing here. So this is, all these little ants running around are individual red blood cells running through the capillaries of the lamina propria. I can tell you for sure that this is somebody with Barrett's esophagus because they have tall columnar epithelium. And I'm also seeing sort of goblet cells here and here. But this is definitely not dysplasia. This is adenocarcinoma. And you really don't see the goblet cells. You don't see that organized architecture. This is high-grade dysplasia. Again, a little bit more of the architecture retained, but nothing like just non-dysplastic Barrett's. Another technology I'm going to very briefly talk about is something that's actually not available on the market currently. It may come back soon, but volumetric laser endomicroscopy. This uses something called optical coherence tomography. And essentially, you put a balloon into the esophagus, is a laser scanning unit, and in about 90 seconds, it's able to scan about 6 centimeters of the esophagus. And then you get this sort of computer generated kind of 3D reconstruction. And there's a fancy remote or screen where you can manipulate the image and find features that might represent dysplasia. So this is sort of normal esophageal mucosa, while these are sort of atypical glands. And then it's a sophisticated system where you can actually laser mark with cautery using the balloon and laser in the balloon to mark where these areas are. Then you go back endoscopically and you look for them carefully, and you can do an endoscopic mucosal resection or some targeted biopsies. This is a case of Dr. Chang's where he actually found some high-grade dysplasia underneath stratified squamous. So this may be something useful for looking for buried Barrett's esophagus. Okay, now above all else, we need to be able to have great image interpretation skills. Now, after you've recognized Barrett's, the next mode is really finding dysplasia. And the mindset that you have to be in when you're seeing somebody with Barrett's esophagus is, there is dysplasia here somewhere, and I'm going to find it. And I think when you have that mindset, then you will look in a very, very different way and at a very high level. And when you're looking, there's really two modes that we sort of switch between. We have this red flag detector mode, which is really just looking for any suspicious lesions, sort of at a higher level. So anything that's raised, depressed, ulcerated, bleeding, even discolored, your red flag detector mode is sort of operating then. Once you see something, you have the sort of in vivo optical pathology mode. You want to get close. You want to interrogate it. And if it looks dysplastic, you can biopsy it, do a mucosal resection, and see. But if you think about the mindset of, there's dysplasia here somewhere and I'm going to find it, and then you kind of break things into sort of red flag detector mode and then in vivo optical pathology mode, you'll do a great job. When it comes to evaluating Barrett's esophagus in sort of the surveillance mode, I'm looking for dysplasia, there's a few things I'm thinking about. There's, I want to prepare the mucosa for examination, and that is really getting the mucosa clean. Like we're doing colonoscopy, we can't have bubbles, we can't have mucus, we can't have debris while we're doing the examination because dysplasia is very, very subtle. Using a distal attachment cap, I do a white light exam from the GE junction up to the top, then I go back down and do a narrowband imaging exam from the G junction up to the top. I freeze the image to study the mucosa at various points. The other thing I do is I palpate the tissue with the cap. Sometimes just touching the cap against the tissue can irritate something that's a little bit firm, something will bleed a little bit, and that little catch of blood is the clue that there's actually some dysplasia there, right there. Take your time. 1 minute per centimeter is a good rule of thumb. And I'm interrogating all suspicious lesions with sort of the near focus feature of the scope. So this is, I'm going to say, a low quality exam. Now they're using a cap, and but I don't know. I think they're moving too fast. It's not really that systematic, and they're just sort of bouncing around. There's a lot of debris, a lot of bubbles, mucus coating the surface. It's really difficult for me to appreciate things here. Third year fellows from last year doing a Barrett's exam, and this fellow didn't actually realize that he was being video recorded. But starting from the G junction, taking their time, a little bit of mucus, wash it away. You can see that the mucosa is so clean here, really, really beautifully clean. So just sucking up any water or liquid, taking pictures periodically or freezing the image, being very systematic about the approach, very smooth. And then he's going to go back down. And in the interest of time, I'm just going to move this a little bit quicker, but doing the same exam with narrowband imaging, taking a really close look, and also sort of interrogating things along the way that potentially could be suspicious for dysplasia. For example, here, zoomed in, looking at an area that that might be potentially suspicious for dysplasia. So this is what I consider a high quality exam. One of the things that we need to realize, we are not trying to examine the esophagus so we can find stuff like this. This is so obvious. If you look with the care that our third year fellow just looked with, there's no question you're not going to miss this. But really, could you miss this? Because these are both examples of intramucosal cancer. This is the type of lesion that we don't want to miss. This is the type of thing that we want to examine carefully using all those tricks and tools and the time so we don't miss this. This is where the sensitivity of our exam needs to be. This is what I believe is the future. And this is something that I've been working on with a company called DocBot. And this is a continuous real-time artificial intelligence algorithm. And now you can see that in this clip, the algorithm is saying that actually all of this area is dysplastic. And again, this algorithm has been trained to recognize patterns consistent with dysplasia. And it's continuously evaluating what's on the screen and generating predictions in a continuous real-time manner. So about 60 predictions per second. And it's really saying that, all of this area looks a little bit fishy and of concern. And in fact, it certainly was. Anybody who's an expert in Barrett's imaging would agree that everything the algorithm is picking out does look concerning. So you can see that this area over here is definitely concerning for dysplasia. But the area up here looks okay. The area on the left, again, looks okay. But it's definitely concerned about what's going on the right there at 3 o'clock. So, quick summary. We all have the tools to up our game in Barrett's imaging. I think using a cap, cleaning the mucosa well, taking your time, being systematic, and being in the correct mindset is really important. There is dysplasia here somewhere, and I'm going to find it. I think we're going to see advancements in endomicroscopy and AI. They're coming, but really nothing beats a thorough examination by a diligent, well-trained endoscopist And with that, I'd like to say thank you very much for your attention. Enjoy the rest of the conference.